So how exactly can we use OCT angiography clinically? What are the applications for the primary care optometrist? So we're going to be focusing on several of these things as we get into the cases that will follow. But what you've already been able to see is that we're going to see early and in many cases much more detailed representation of the vascular anatomy and even pathology. So we're going to be looking at things that we aren't necessarily able to detect clinically. And this type of information can change the way we care for our patient. It can lead to a more aggressive follow-up schedule. It can lead to different patient education. It can lead to different referrals. It may reduce the need for a referral because in many cases where we were relying on the dye-based angiograms to confirm or deny the presence of a leakage or a membrane, for example, or macular edema, that we may not necessarily need that anymore. In many cases, it's going to reduce the need for that extra trip for the patient. We can also use it to monitor the regression or the progression of a condition. For example, if the patient is given a injection for an anti-VEGF injection for a choroidal neovascular membrane by the retinal specialist, then that condition can be monitored over time as we watch for the flow within that neovascular net to reduce. And so the retinal specialist can use it to determine the need for follow-ups, the need for retreatment, and of course there's co-management applications in there for us as well. Another really interesting part of OCT angiography and something that I'm really excited about is that we're understanding disease processes in a totally different way because of this technology. And this concept can be applied to conventional OCT as well. 15 years ago, before we understood the stages of a macular hole, for example, the same type of concept is being applied with angiography, where we're learning new things about the vascular pathogenesis of conditions that we haven't known before. And this leads to very strong potential in clinical applications as the technology and understanding advances. Specifically looking at vascular abnormalities, we can really look for some things that we don't see clinically. So we can look for the source of macular edema, for example. We can visualize changes in the deep capillary plexus, such as non-perfusion and microaneurysms, enlargement of the foveolae vascular zone. And most of this is very subclinical detection. So again, honing in on a lot of the conditions that we treat every day and just approaching those in a completely different way because of the information.
So looking at an example where we can really see vascular abnormalities in high detail with OCT angiography is this patient with diabetic retinopathy. And what I've done is just put side by side the color fundus photograph and then the OCT angiography image to help you appreciate all the things, all the subtleties that you're going to be able to visualize with OCT angiography that you were missing with your clinical examination. And so in this particular case, we can see this patient has some areas that look like ERMA or retinal telangiectasias, some areas of non-perfusion that weren't visible with our fundus examination or photography alone. Another utility of OCT angiography in highlighting vascular abnormalities is going to actually be identifying sources of edema. And this may seem counterintuitive. You're saying, well, if we don't see leakage with OCT angiography, how do we know what is leaking, where it's coming from? But there are a lot of inferences that you can make because we have that vascular and structural data in tandem. And so here is a patient with some very subtle diabetic retinopathy. You can see there's just a little bit of thickening on the thickness map there on the temporal foveal region. And where that thickening is coming from, we're able to easily see on the superficial map of OCT angiography that there's a large microaneurysm there that's causing just a little bit of cystic fluid. And so certainly if this was further from the foveal vascular zone, it's such a small point source of leakage, this may be more amenable to focal macular photocoagulation treatment than anti-VEGF treatment. So there are instances where this may change your treatment plan for a patient.
So there's several clinical scenarios where we're able to apply the concept of subclinical disease detection from OCT angiography, diabetic retinopathy being a very classic example of this. So if we focus on this patient example here, patient with a history of diabetes where clinically manifestations were not detected. So clinical exam did not detect any sign of retinopathy. But if we look at our patient's OCT angiography images over on the right-hand side of the screen here, looking at the top of the superficial plexus and then the bottom image is the deep, comparing those to the normal on the left-hand side, what you see are areas of less vasculature. You see a lot more black, and all that black means non-perfusion. You have capillary dropout, and what's highlighted in the deep capillary plexus is often the enlargement of the foveolae vascular zone and areas where we see some microaneurysms. So earlier detection, totally different set of guidelines that I now use for talking to my patient. I'm going to be more aggressive with the follow-up, and this is going to be really helpful information for the primary care doctor as well. So we'll see in examples later that OCT angiography can be very useful in the case of an acute vascular occlusive event, whether it be artery or vein occlusion or ischemic optic neuropathy. But it's also very useful in the case of an old event, an event that's occurred previously where you have some confusing evidence, you're not exactly sure what the etiology may be of reduced acuity or poor visual function or other vascular changes. And so this example, what we see here in the total retinal vascular representation here, which is the en face image that's been selected here, is again, we see non-perfusion, we see loss of vascular organization, but if you can direct your attention to the top right-hand area of the retinal vascular en face image, what you see is an abnormal vessel appearance. We have a collateral vessel here, so this is consistent with an old branch retinal vein occlusion, for example. And of course, you can correlate that with the data otherwise for the patient at hand.
I really love this example. I mean, there have been so many times where there's been really chronic, old, long-standing, even small, like twig branch retinal vein occlusions, and the findings can be so subtle. And
Right.
here, OCT angiography really highlights that for you. So if you have a case of unexplained acuity, you may be able to explain it by doing OCT angiography when your
Yeah.
clinical exam was lacking.
And in this example, the other thing to highlight is that once you see this abnormality, it's important to be sure that it is in fact a collateral and nothing that actually needs treatment. So if we highlight the area of the vitreoretinal interface, which is not magnified in this image, but you can see in the smaller thumbnails to the left, that there's nothing there. And that's exactly what we would expect when there's not retinal neovascularization. So of course, this does help us confirm and be a little less urgent in our thoughts about what's actually going on here with this patient.
Yeah, differentiating collaterals versus preretinal neo, which is a very important distinction to make because it affects your management. Another application of subclinical disease detection is looking at early macular telangiectasia type 2. And so macular telangiectasia type 2 usually onsets in about the 5th decade, causing slowly progressive vision loss in both eyes. And the early signs of macular telangiectasia type 2 can be incredibly subtle vascular changes, usually occurring in the temporal region of the fovea and the temporal aspect of the foveolae vascular zone. And so in this particular patient here, this patient was actually referred to me with a possible macular hole, but OCT angiography makes it incredibly clear that there are just these telangiectatic type vessels that are pretty much 360 degrees around the foveolae vascular zone, associated with some atrophy of the outer retina that we can visualize with our structural B scan. Another main clinical application of OCT angiography is visualizing non-perfusion, and I like to call this seeing the invisible, because with our clinical examination, we really don't see retinal non-perfusion, we can't visualize choroidal non-perfusion. We really need some sort of technology, whether that's IV fluorescein angiography or OCT angiography, to visualize that for us. And why not choose OCT angiography? Because it's a non-invasive test. And so we can separate out or classify non-perfusion depending on blood supply source. And so we can divide it out as retinal, choroidal, or of the disc or radial peripapillary capillary plexus. And so retinal non-perfusion occurs most commonly in conditions like diabetic retinopathy, venous occlusive disease, whereas choroidal non-perfusion, we're going to see the main application is in AMD, but also can occur in other conditions such as giant cell arteritis, ocular ischemic syndrome, which may affect both retinal and choroidal circulation systems. And then looking at the optic disc perfusion or radial peripapillary capillary plexus, the main clinical application is going to be glaucoma or other optic neuropathies. And so this is one of my patients with proliferative diabetic retinopathy. And I think what's really shocking about the OCT angiography, and so this is a montage, so this is a 14 by 14 millimeter scan. There's massive peripheral and mid-peripheral non-perfusion that we're not able to see with our clinical examination or with color fundus photography here on the left. And so this would have been data that we were missing if we didn't have OCT angiography. And I think this is probably fueling the growth of neovascular membranes which were located on the disc and elsewhere in this particular patient. So there's a trend in practice today towards treating patients with anti-VEGF agents or even PRP or laser earlier on in the course of the disease. And the thought process is, why wait until proliferation? Why wait until diabetic macular edema affects the acuity? Can't we just prevent that from the get-go by perhaps doing, EYLEA injections every 3 months? And so this is the investigation that's going on with the drcr.net, Protocol W. Can't wait for the results of that to come out. But I think OCT angiography helps you decide which patients should we treat early and which patients should we not. And so here I've taken one of my favorite tables from the AAO preferred practice pattern. So this is straight from Standard of Care 2017 when it was last updated. And they're even suggesting that in severe non-proliferative diabetic retinopathy without diabetic macular edema, so all there is the retinopathy alone, anti-VEGF agents may be indicated sometimes. And so how do you determine who those lucky patients are that get treatment? What are those times that you actually treat? I think OCT angiography will allow you to see this massive peripheral non-perfusion. That's going to be a patient that I'm going to recommend treatment for. I know there's a high risk for that patient to go on and become proliferative within the next few months. So it's going to help me decide in that nebulous sometime zone who deserves treatment and who can I just monitor.
So in addition to diabetic retinopathy, we know that there are multiple different conditions in the retina where we're looking for non-perfusion. Of course, branch retinal vein occlusion is demonstrated here. And if you recall, differentiating between an ischemic and a non-ischemic branch retinal vein occlusion or central retinal vein occlusion is crucial in determining the follow-up pattern, the treatment strategies, and the risk and prognosis for visual outcome. So we can now do that in a non-invasive way with OCT angiography like you see here. It's clear that in this representation there's greater than 5 disc diameters of non-perfusion, and it's dipping down into that macular area. So that's useful in determining how aggressively we want to follow up with this patient. So based on literature, we know that up to 50% of these eyes with an ischemic branch retinal vein occlusion are going to develop neovascularization of the disc or elsewhere. And so again, just highlighting what we know from previous literature, applying that to today's technology, we're able to find that information in a much more easy, non-invasive, less expensive way. And so that changes the way we follow that patient. So if we really hone in on the macular area in any sort of a venous occlusive event, we know that visual acuity and visual function can be reduced either because of macular edema or non-perfusion, macular ischemia. And of course, again, highlighting the fact that with OCTA, we can get that information very easily. And we can compare and correlate the data with the structural macular edema that's noted here on the bottom of the screen with the area of non-perfusion, and again with that representation of the clinical fundus exam that you see on the top left. We also know that when there's macular edema present, there is more likely to be change in vasculature, and this is again an area where OCTA has taught us about the vascular pathogenesis of a condition. We not only know that there's going to be non-perfusion in the areas of macular edema, there's going to be measurable eventually vessel density changes, changes in the superficial and the deep capillary plexus, microaneurysms may be present. And these patients actually have a poorer response to therapy. So when we send them to the retinal specialist to get that anti-VEGF injection, they're less likely to respond. And that's really useful for the retinal consultant, and it's also useful for them to determine need for retreatment following that condition over time.
We can treat macular edema, but we can't treat macular ischemia at this time. And so if I see a patient that has both going on, I know I can treat the edema component, but I'm going to educate that patient that there's a guarded prognosis because there's a lot of ischemia there. We might not hit like a perfect, 20/20 acuity after treatment. We're probably looking at something more like 20/40. And that takes some clinical experience, I think, knowing how much macular ischemia there is and what visual acuity that correlates with. This is one of my patients with intermediate non-exudative age-related macular degeneration, and what we can see are some drusenoid deposits that are nicely highlighted in our structural in-phos image there in the center, and then directly underneath these drusenoid deposits are areas of choriocapillaris hypoperfusion. And so the question is, the classic chicken or the egg thing, like what came first? Is it the hypoperfusion of the choriocapillaris that fueled the development of the drusen, or is it the drusen that somehow disrupted the integrity of the choriocapillaris? Can't wait for longitudinal studies to come out to show us, how is this involved in the pathogenesis. But research thus far suggests that it certainly is not just shadowing effect. Even if we compensate for the shadowing effect of the drusen themselves, this hypoperfusion is still present. This is a real thing that's occurring underneath drusen in AMD. We can also visualize non-perfusion surrounding zones of geographic atrophy in non-exudative AMD. And again, the question is this involved in the pathogenesis of geographic atrophy and geographic atrophy expansion? And so longitudinal studies are going to be really exciting in this realm. Probably eyes that have large areas of non-perfusion surrounding geographic atrophy are going to be more likely to enlarge or progress at a faster rate than eyes that don't. And so this will be a tool, I think, that we can use to educate our patients what's the prognosis for enlargement over time. I want to share with you a case that got me really excited when I saw this. And so this was a patient that presented with adult onset Best disease, was misdiagnosed previously as AMD. The first thing about this case that shocked me, and I'm just showing you the left eye here, is that the vitelliform deposit in the macula itself was vascularized, which I couldn't appreciate with clinical exam, but it was very well vascularized that we can see in the bottom left-hand image, the in-fos OCT angiography baseline scan there. The other thing that shocked me is on the baseline scan, you can see towards the top that there was a hypoperfused area of the choriocapillaris. I'm going to be honest with you, I didn't even see this at the baseline examination, nor did I think much of it. But then on the 9-month follow-up, so we referred him for treatment. He unfortunately just kind of was lost to follow-up. When he comes back 9 months later, there was actually development of a choroidal neovascular membrane that is active. So we can see there's subretinal hemorrhage surrounding it. And so I was shocked by this case. Can hypoperfusion of the choriocapillaris predict where choroidal neovascularization is going to form? And is this involved in the pathogenesis of adult onset Best disease? You know, the research is yet to come.
So what about with our glaucoma patients? We can think about non-perfusion as well here. What we can actually do is look subjectively at the perfusion around the disc and around the macular area. You can see here where this red arrow points to a nice wedge-shaped nerve fiber layer defect actually corresponds quite nicely to loss in vasculature. So we can compare this to a structural loss on a conventional OCT or a red-free image, for example, and we are going to expect here to see a corresponding visual field loss as well. So what we're looking at is loss of the radial papillary capillaries around the disc, and this is going to be a vascular supply that originates from the central retinal artery. It's a very superficial blood supply that feeds the RNFL. And this is conventionally something that we are not able to visualize with dye-based fluorescein angiography. So in itself, this has many clinical implications. We still have a lot to learn about what OCTA can do for us in the care of our glaucoma patients, whether it be early detection, better correlation of data, or just looking carefully for progression over time in a different way with different information, correlating all of those together, structure, function, vascular anatomy. But there's definitely strong evidence and a whole lot of potential in terms of what this technology is going to be doing for us in the future. So this is something we have to pay careful attention to in the near future.
In glaucoma, there's non-perfusion of the radial peripapillary capillary plexus immediately surrounding the disc and in the macular region. So I think what's important at this time is that you're doing both scans. So you're getting that 4.5 millimeter scan on the optic nerve, and you're also getting that 6 millimeter macular scan. That way, when quantitative analysis comes out, we can retroactively apply that to this, the previous scans that we've taken, and we're able to say, is there objective progression in terms of decreased perfusion, decreased function over time? So it's going to be another tool that we have in our tool belt, I think, to monitor and even
Absolutely.
potentially diagnose early glaucoma.
Mm-hmm.